Are you comfortable in commenting the relationship between root canals and cavitation?
I'm always comfortable commenting on anything. I just don't. I have not seen any research that has tied it together. I just hear a lot of people say, well, in my practice it's bad, and I took the root canal out, and the patient's heart got better, and things like that. It really does bug me. I will say that people don't try to do more in-depth research to establish those connections. You look at, there's another connection that's very similar, and that's all these systemic connections with periodontal disease. And periodontists got their hands burned very, very hard and very early on, maybe 12 or 13 years ago, because they were finding an association and saying this is a cause and effect. And then as real research came along, they found that it's not cause and effect. And cases, it's just an underlying common third cause that has nothing to do with either of those. And be careful. And I try to, whether I'm in a university or not, I try to follow whatever the evidence base is. And in that particular category, I don't think we've got the evidence base. Although I wouldn't be at all surprised that there is a connection. It's just that we need some more proof. And actually, I found the endodontists are the ones most looking into this. They're the ones doing all the research on all the toxins and things like that, and the apical. Keep in mind that the endodontists are only doing 5 to 10% of all of the root canals. We're general dentists are doing a great majority.
Questions for Ann Summers. Realizing that human cells are, of course, much different than bacteria, this association with the increasing mercury levels and then the free iron, being that may be an association that we would see in human cells. I mean, I don't want to make too much of a...
No one has yet asked, and I wouldn't maintain that that's the case. It requires an experiment.
Right, okay. But I guess what my concern is that if we're using things like ozone to treat patients who have alloys, is whether or not we would be perhaps better serving our patients if we took the alloys out first before we start using the ozone treatment.
I can't make any comment on clinical practice.
Okay.
Sorry.
That's all right.
Yeah.
Dr. Summers, I have a question for you. I don't know, maybe I misunderstood, but when you were talking about the binding of the cysteine to the mercury group, you made a comment, I think, that it was very difficult for the body to remove that. And was there a context in, like, for chelation or removal of the mercury from the body attached to cysteine versus glutathione?
Oh, not in my work. I'm just talking about the basic chemistry of monothiol adducts and bis-coordinated adducts, and that's a well-established chemistry. And it certainly is going to apply to the recovery of mercury from biological tissues. But I haven't done that. I mean, what I said was, yes, cysteine bonds, cysteine is going to bind much more firmly to mercury than acetate will, for example. And that's what that chart that I showed was, that acetate's a weak ligand, and cysteine, which is represented by SR, in other words, an organic thiol group of some kind, would bind very strongly, by orders of magnitude more strongly, to mercury than an acetate or a chloride or bromide would. But a monothiol adduct that would bind on one side. If you have a mercury atom, okay, and you've got a monothiol, which is what cysteine is, it has only one sulfur group, and it comes in and binds one of those available coordinations domains on mercury, and another one that comes in, and they're two there together, but they're not connected to each other, okay, then either one of them can be exchanged very readily, okay, and that was the second slide. That's a high-speed process. Mercury-sulfur association is thermodynamically stable, okay, but it's kinetically labile with another file. So you can interchange. I mean, there is some tuning to this, but it's just a couple of orders of magnitude difference between them, whereas it's, 15 orders of magnitude difference between thiols and halides, for example, and acetate. Okay? But you have what's called the collation effect, where you have two cysteines that are connected, okay, through my shoulders. Okay? Those two cysteines might be in a protein. Okay? And if they're binding mercury, they have a 5 order of magnitude, 100,000-fold advantage in terms of their stability and exchangeability with respect to the typical kinds of things that we have in our own physiology. Glutathione is a monothiol. Cysteine is a monothiol. Lipoic acid is a monothiol, all the ones we build ourselves. Ain't going to do it with bis-coordinated mercury. I don't know if that gets where you're going. Okay. Yeah.
Yes, this is for Dr. Bucquot. Is there a method of detecting these bone lesions that is recognized by certain other individuals that justifies their surgery and or intervention? I mean, I'm talking about 3D, I know the cavitat story, that sort of thing, but is the 3D cone beam something that they will recognize as being?
Well, if you look at the orthopedic literature, the ways to diagnose this disease in its sort of most common generic form, the bone marrow edema form, is to take an MRI. But they're dealing with hips and knees, and they have these nice round balls of marrow, and it's easy to see some kind of a disease pattern. And as a matter of fact, the hip, this disease is now diagnosed in the hip by the radiologists. They're not doing a biopsy. And early on, I looked at a lot of MRIs, and the jaws are just too irregular, and we don't have enough marrow to see that kind of pattern. The orthopedic surgeons have been using the Tech 99 bone scan. If you see a hot spot, there is only a 3% false positive rate. So if you see a hot spot, you know something has to be in there, and that should be enough justification, especially in somebody who's got pain. Another thing is radiolucency. I've just submitted a paper on 600 plus examples of what we in oral path call focal osteoporotic marrow defect. Some of you might know it as a hematopoietic marrow defect. And I'm doing this with several other oral pathologists and one medical pathologist from Switzerland. And they insisted in the discussion that we recommended biopsy. Hello? Oh, okay. Where was I? Yeah, they insisted that we put in the discussion a sentence that anytime there is an ill-defined radiolucency in the bone, there should be at least some kind of biopsy or diagnostic test done to determine what it is. Some of you have my textbook or our textbook, and one of the things that is the most popular part of that textbook is the appendix. And the appendix is a bunch of list of diseases, all the white lesions that look well-defined, all those with ill-defined borders, etc. It's a list of differential diagnosis entities. And if you look on that list, that list, by the way, was my handout in West Virginia University for many, many years, and Brad Neville was my student, and he insisted that we put that in as the appendix. But if you look on that list of ill-defined radiolucencies, it's about 7 things and none of them are good. NICO is listed there as well. But we've got things like lymphoma, multiple myeloma, odontogenic myxoma. There isn't a good thing other than that ill-defined, other than that focal osteoporotic marrow defect. So if you can see something radiographically in that site, then that's justification as well. But does a cone beam CT help? I get 2 or 3 of those every week, and I'm looking at them, and I get kind of desperate because I get so far behind on things. But it, to me, has helped a lot, but I find that dentists are so used to seeing odd trabecular patterns on x-rays. When they see them on a cone beam, they're more pronounced, and they just assume that it's a variation of normal, even though nobody ever has gone in to biopsy those odd trabecular patterns, except in this disease, this ischemic bone disease, NICO. So cone beam, I think, is good, but you need to have that suspicious eye, and if you're recommending, if you're not a surgeon and you want some surgery, you're going to have to talk an oral surgeon into seeing what you see. I want to give people a warning. I didn't find this out myself till 6 or 7 years ago when I was on a master's thesis committee at WVU. The FBI has a fingerprint division just 40 minutes down the road from my old West Virginia University, and they have a program now that turns fingerprints into the Alps. It looks like black mountains, and you can see every pore looks like a volcano opening. And they gave us that program because they knew about us, and they thought maybe dentists were dealing with black and white. Maybe they can find these subtle lesions. Well, it didn't turn out to help that much. You have to really think. But as part of that process, the resident showed me a paper that essentially demonstrated that some of us can only see 6 shades of black and white, or 6 shades of gray, I guess, whereas others can see up to 36 shades of gray. And I happen to be able to see 34 shades of gray. And I've shown lots of these NICO lesions to good friends who trust me, and they eventually did go in and do this surgery, but they could not see the lesion on regular x-rays. I don't see why CT scan would be any different. There is a slice and dice 3D component to some of the CD scans, or CT scans, and maybe that will be helpful. But you still have to be willing to say that's something I want to look at, not just something is abnormal there. I want to point out, I don't know if it's part of getting old and I want to give my stuff away, but for the past 5 or 6 years I've been giving away a program called the 53 Most Common Oral Lesions. And as time went on, people told me they liked the format. I call them hyperlink handouts. They're handouts where you can just press buttons and jump back and forth as if you're on the web, and eventually it will be a web product. But I developed several other programs for that, and I eventually decided about 3 or 4 years ago to call it BOCO to Go. So this is, I've given it to Dave Kennedy and your leadership, and if you want to get it from them, it's free. If you want to contact me, I have to charge you $10 to cover the handling fees, that's all. But there are over 3,000 pictures, most of them clinical pictures. There is over 1,000 pictures are an ischemic, I call it just chronic ischemic bone disease. A lot of that is microscopic stuff, but there are lots of x-rays and lots of cone beams, lots of Tech 99 scans, and that's available to you. That was kind of a wandering discussion.
I had a follow-up question to that relative to the cone beam evaluation of root canal treated teeth, and I've heard some specialists, endodontists and oral surgeons, refer to periapical lesions in these situations as apical scarring. Do you have any comment about that? Is that a new term that specialists are beginning to use, and what does it mean? Is it pathological or not?
I was taught that in the 1960s when I went to dental school, so I don't think it's a new term. But it is essentially somewhere around 6, 7, 8%. I saw, I think, as much as 12% of one study where those were determined, radiographically determined, not biopsy. Essentially, it's an endodontic process or treatment that ends up with an excess of fibrous tissue. And it looks just like scar tissue in the soft tissue. And you might have seen me smile just then because I have over 12,000 bone marrow samples submitted from dentists and physicians all over the world, really. And most of them, they suspect ischemic or inflammatory disease. And to put that in perspective, a typical oral path biopsy service might get 2 or 3 bone marrows a year. So, mine is a very unique service, and I've always made it available to anybody who wants to look at it. But because I have all this vast experience, as part of the classification system for ischemic bone problems or bone marrow problems, I had to invent this term called intramedullary fibrous scar, which I presented to our Oral Path Academy last year, and that seems to have caught on. It's pretty easy to diagnose. You just get that dense scar tissue, and it's really the equivalent of what goes on in the apex of a tooth. And we find them in extraction sites. We find them sort of de novo in places between the roots. I think they're areas that used to be infarcted in some cases. Whatever caused that marrow to be destroyed, when it healed, it ended up with fibrous scar tissue. And of course, there are a lot of cytokines and chemicals that can lead to poor healing. However, it may be just simple ischemia in those areas. I don't know. The periapical scar is not new, and the assumption is the assumption by the endodontist is this is a clinically successful treatment. But clinical success is supposed to be no apical radiolucency and no pain. That's the definition.
Well, do you think we're justified to see a dark spot on a cone beam and a 3D projection of a tooth and say, therefore, that is pathology, tooth has to be extracted or retreated or something?
If you see something apically, and I think this is going to happen as more and more cone beams hit the dental offices, you're going to see more of those because it's much more obvious. And it would be really, as far as I can see, it's the same as if you found the same thing on an x-ray. You've got to either do something or decide on a short list of possible diseases that you're not worried about, and therefore you don't do it. And then you justify that by putting it in the record. That's about it. But yeah, I think the cone beam doesn't make any difference. I just published in a textbook on cone beam interpretation, the pathology chapter, and that was one of the comments I made in there. If you have a pathology, you've got to do something about it. That's actually the hottest topic right now in cone beam CT scans. You're a dentist, you want to look at the teeth, but you've got all this other tissue involved, and you are legally responsible for every piece of image that comes out of that machine. And are you able to recognize all that? Oral pathology might become more important.
Well, I have a question for Dr. Walker. Why can't my wife sleep?
Look at a mirror. Is it she can't sleep, she can't get to sleep, or she can't stay asleep? Depends on the age, but a whole lot of the ability to go through those stages of sleep is related to hormones and progesterone. The biggest cause is low progesterone. And when it comes to sleep stages, the progesterone creams don't help. So when it comes to sleep stages and hormones and progesterone, only the oral progesterones help sleep. And they're not used very much. Instead, they're using horse urine and stuff like that. Whereas the actual bioidentical oral progesterone is one of those things that you want to check for. And mainly because if you don't have that, you've got unopposed estrogen, which is what's setting up breast cancer. I mean, we know what's causing the breast cancers. 4-hydroxyestrogen. And you can't methylate that if you're toxic. So two things you check is estrogen metabolites and progesterone levels in the blood. But it's a progesterone thing. Very, 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 very common. And you probably snore.
But he's still a nice guy.
Yeah. That's why one of the symptoms of snoring is rib pain.
Dr. Walker, what's your opinion with why so many pain patients are on Synthroid? What's the thyroid and pain connection?
And when you're in pain, the part of your brain, your reticular activating system, you'll get heightened activity in the reticular system, which causes heightened activity in the cortisol system. And if you have cortisol, your body says, why the heck do I need thyroid to ramp up my metabolic rate? And all available T3 goes to something called reverse T3. And a drain to reverse T3 signals the brain to increase thyroid stimulating hormone, which is what doctors see, and they say, oh, well, we'll just give you T4, Synthroid, to make TSH go down. T4 isn't active on any cells. It only feeds back to the brain. Your body needs T3 to work, which you should always check, because T3 is what really signals the body to stop needing thyroid. But anytime you're in pain, available thyroid goes to reverse T3 and makes TSH go up. So you get a medical doctor giving you Synthroid, which doesn't work, but it increases, it levels the thing out. Has to do with pain, cortisol, and thyroid competition. But anytime you check thyroid, you check TSH and T4, which tell you whether you have primary serious issues. But always check free T3 and reverse T3 if you want to see how it functions in the body. And reverse T3 equals cortisol. Make sense? Lori?
To support the adrenals?
When we talk about adrenals, are you talking about epinephrine or cortisol?
Cortisol.
Because they're both adrenals, right? Most of the time what we want to support is epinephrine and decrease cortisol. So we're stimulating one part and decreasing the other part. So people use adrenals as a word, and you have to realize that your adrenal cortex works with your brain cortex. Perceived stress. Your adrenal medulla works with your brain stem medulla. Physiologic stress. They're different things. What we want is a good medulla and a quiet cortex. So you want your adrenals to meditate.
How do you support epinephrine?
You can stimulate epinephrine production. Number one thing that stimulates epinephrine is protein. Higher protein. You need at least 60 to 70 grams of protein per day to calm down cortisol and stimulate epinephrine. What amino acid makes epinephrine, Lori? Tyrosine. What else does tyrosine make? Dopamine, norepinephrine, and, Lori, thyroxine. So you have a direct competition and a decrease in epinephrine, a decrease in norepinephrine, pain control, a decrease in dopamine, and a decrease in thyroxine whenever you have an increase in cortisol. So thyroxine or tyrosine is one of the things you want to increase in all those cases. But overall protein, B1, B vitamins, all of your B vitamins need to be up. your vitamin C needs to be up, and your minerals need to be up. That's why we stuck them all together.
You make a distinction between vegetarian and animal protein?
Most vegetarian proteins are not complete unless you blend them. And you have to usually blend about 4 different vegetables to get complete amino acid profiles. And that's why you have to look at the amino acid profiles in vegan-type proteins. You can get your protein complement from vegetarian sources. You have to be diligent. It's not as easy to get a complement of it, but yes, you can. I mean, it took us 7 different vegetables to get a complete amino acid profile that's equal to, say, a hunk of beef. But yeah, you can. You just have to be much more conscious of what you're doing.
Mark, have you had any feedback from the FDA since your presentation in December?
Do you count total silence as feedback? I've told a number of people this. I was approached by them early on about the possibility of aiding them in some way through a program called Special Government Employee. It's in Canada, we call it a casual employee. You can come on for so many days, 90 to 100 days or something like that. And I was asked if I was interested, and I checked the feasibility of getting the right work permits and all that, sent them back a note saying, yeah, that would work. I've not heard a thing from them since. So,
You're hoping to say no.
well, that's a possibility. And it depends where that decision's being made and whatever. But that's it.
Dr. Summers, you mentioned the failure to realize the promise of the Genome Project, the human genome, and apparently Mercury's interfered with that, and I really didn't understand all that.
I would say that Mercury could interfere with that. The subject of the human genome's contribution to many diseases that have been looked at as possibly caused by a single gene has had some successes. Certainly the BRCA genes for breast cancer and the APO gene for Alzheimer's risk. But those, as in most cases, only account for a small proportion. There are familial genes like that have been identified as clearly inheritable, and families have them and so forth, and they've been recognized. There are very many fewer than one had hoped for. And the kinds of studies that are being done now are much more broadly based. They're looking at what are called single nucleotide polymorphisms, which is basically going out and looking for any kind of little dimple in the genome at the DNA base level to see if it's possibly associated with a disease cohort. There are no big winners out of any of that. I mean, the general conclusion that's moving forward is not surprising and very realistic in many ways, and that is, well, these are very complicated systems, and the phenotypes that we're looking for are kind of grossly defined. So, in the first place, they're probably multigenic. In other words, more than one gene gives rise to schizophrenia or the susceptibility to schizophrenia. And so that's just the way it's going to be. We've got the low-hanging fruit with a few, but that hasn't stopped a lot of people from looking for additional single gene associations. There's a lot of that going on. There's the other layer that has come aboard in just about the last 3 years, and that's in terms of the general public, and that's epigenetics. There's the DNA sequence itself, and then our bodies at every stage of development are making methylation marks on the DNA that change its individual expression, its individual implementation, even between identical twins. So it is, and that's not something it's getting better, but it's not easy to read out the epigenome to look and see, okay, exactly how methylated is this sequence, because that'll have differences in different organs. So it's a tremendous technical and informatics problem that people are sort of now faced with if they're going to figure out by just kind of piecemeal methods, in a way, even though they're highly sophisticated methods, one base pair at a time, as to which gene might be associated with a given clinical manifestation, aka a disease or syndrome. So, yeah, the blush is off the, this is the answer to modern medicine. We'll just go down and, oh, that gene, so you've got this, so we'll make that pill and you'll be better. Which we all kind of think, what? It's a way to sell an idea to in a context, particularly for federal funding. And I don't really want to go into that, but it's a way to sell something to people who really aren't all that interested in it anyway. I think there is still tremendous promise, and understanding the genome is enormously important, but it's very frustrating in applying it to things like a pill for a specific diagnosis, or being able to counsel a couple as to what likelihood they have of having a particular chronic or neurological disease in a child. And that is the frustration I was talking about. It's to the degree that some of them, since there are so many obvious and frank neuropathologies associated with mercury, that's one that you can say, well, why don't people put 2 and 2 together, okay, and see if there are not, and let's not leave it to mercury, let's talk about other kinds of electrophiles that might have neurological sequelae. Where is toxicology in genetic screening? And nowhere, basically. I mean, it's coming along, and it's been a long, hard fight. And if Dr. Sook was here still, I'm certain could contribute to that. The toxicologists themselves are much more making this point now, that you folks are really, wasting your time trying to screen for drugs with a population, some subset of which may be seriously compromised in ways that you don't know anything about due to environmental toxins of various kinds. The reason mercury is of interest to me and others is because it is so prevalent through the amalgam exposure. There just ain't anything else like it. You'd have to eat your blue plastic water bottles or something like that to get that much corresponding, molar exposure. So, I mean, I don't know if I answered your question, but I mean, that was what I was saying, is that the easier it can be to have a facile, function-specific detection, what everybody realizes, everybody agrees, oh yes, this particular gene is clearly functional in these diseases, but we don't have any polymorphisms in these people. They don't have any of the associated polymorphisms, so they can't possibly have this disease even though it looks like they have this disease. And they're not really looking at that protein in that person to see what degree of compromise that protein in that person might have. And that's been where we're trying to go with one electrophile, is to do that. Thanks.
To any of you, very specifically, Steve Coral and I were discussing the MTHFR SNP, and that apparently affects mercury detoxification, and we didn't understand how.
MTHFR is... MTH. Okay. Is involved in mercury detoxification? And this is in what context?
It's my understanding, at least when you have that, you're likely to be more toxic from a given mercury exposure.
We have an acronym for it. The MTHFR enzyme system, when you do have a SNP in that, one of the problems is in methylation. Not the sulfonation pathways, but the methylation pathways. And it doesn't allow proper methylation, especially folate versus folinic acid, and a lot of the methyl donors aren't having. Now, we do see it a lot in breast cancers. We do see a high buildup of metabolites of hydroxys and not methyl metabolites. So the intermediates build up in the system, and overall liver function gets very, very, very taxed. And that's why it's not so much in the mercury, which tends to be sulfonated, correct?
Yes, mostly. Not sulfonate, but thiol, sulfur.
Thiols, yeah.
Right.
So the disulfide bonds that we're trying to get to grab in that for more metals. But when it comes to a lot of your own metabolic toxins, they are primarily methylated, and you don't have that methyl enzyme that helps bind and conjugate to get out of the system. So you have a large buildup of reactive intermediaries in the system. So it's much more in the other things, and it's an overwork of the system. Now, if you can't methylate, how are you going to try to get other toxins out? That's where we see the sulforaphans and some of the other groups trying to take over those roles. So it's a competition after that.
And the methyl B12, certainly.
I'd just like to make a quick comment. That particular mutation is one that we found in these NICO lesions at a high proportion, and leads to a hypercoagulation state. There are about 16 or 18 or so of those that weren't even identified 20, 25 years ago. But in the ischemic cases, these are all pain patients that I'm talking about now. In those cases, 73% have one form or another inherited hypercoagulation state. That's a common denominator. I don't know if it's cause and effect, but it's a common denominator.
I was interested. I think you had telomerase as one of your signature. Is that correct?
No.
Nope.
No.
Okay.
No, that's somebody else.
Right.
Those, and even in NICO, what kind of toxins do you have a lot of buildup? Metabolic debris. And you can't clear that when you have methyltransferase SNPs.
Are there any more questions? Beer?
Beer 30.
Can we start by applauding this young lady who organizes all our meetings single-handedly and does such a wonderful job, Dr. Janet Skopka from Chicago. Thank you for another beautiful meeting. Thank you to our wonderful panel who stayed this evening to answer the questions. I'm always impressed with the science of these people, the integrity, and their sincere concern for safety in healthcare and coming to talk to our academy. Thank you so much, all of you. Thank you for your sincere interest in all of this. We hope sincerely to see you in Vegas. Who's coming to Vegas? Hey, here. We'll see you there, and have a safe trip back home. It was a great meeting. Thank you for coming.